Welcome everyone. Very good afternoon to all of you. Welcome to Clinical Thursday session on DocTutorials. I am Dr. Rohith Daniel, your Orthopedics faculty. It's wonderful to have all of you here. And as you all know, Clinical Thursdays have been designed to teach you clinical aspects of certain important topics that are very often asked for your NEET as well as your INI-CT exam. And today I'll be sharing such a clinical case. As many of you would have already known, if you are following me on Instagram, I had today posted a case scenario of a nerve injury. The same thing that we'll be discussing here. Along with that case, we'll also be discussing certain important points regarding radial nerve injuries, which is a very, very commonly asked topic for your exam. All right. So we'll start. So a patient around 50 to 55-year-old, he actually came to me around 2 months back, and he sat in front of me, and I asked him what happened. He was initially very reluctant to answer me. So I said, don't worry, sir, just chill, just tell me what happened. And then slowly he told me a story. He said that over a very small matter, he had a fight with his neighbor. Initially, it started off as a verbal abuse among each other. Then it quickly escalated into a fight. And the neighbor assaulted my patient with a stick. And he has come with an injury to his left upper limb. That is the clinical history. Assault by neighbor, and he has sustained an injury to his left upper limb. And because of that, he has two complaints. One obviously is pain around the elbow. He said that there is some pain and swelling around his left elbow that is often seen after an injury. But second was a very interesting symptom. He said that he has difficulty in grasping things. Okay, I told him, is it because of pain in your fingers or wrist or something like that? He said, no, sir, it is because I'm not able to extend my fingers. Everything else is working, but my fingers are not extending properly. I said, oh, now that is a very interesting symptom, not very commonly seen, isn't it? So what will we do next? Obviously, we are going to evaluate the patient. And being an orthopedician, first thing we would do is what? We'll examine the bones and the joints to see if there is any fracture or dislocation or anything like that. Okay. So when I examined the patient, I saw that there was some tenderness and edema around the proximal forearm. But the flexion, extension of the elbow, everything was normal. There was no problem at all. Okay. And this gentleman had actually brought in an X-ray to me. Okay. He, even before consulting the doctor, he went to a nearby X-ray center, took an X-ray, and he has brought me this X-ray. Now, I would like you to tell me if there is anything that is abnormal in this X-ray. I'll give you a few seconds to evaluate this X-ray. All right. So can you just type in if there is any problem in the X-ray in your chat box or in the YouTube comment section? Is there any problem? Yes. This X-ray is absolutely normal. There are no fractures or dislocations or anything. This X-ray is absolutely normal. No problem at all. Then this means that because of the injury, there has been no trauma, but no fractures or dislocations. But there is some problem with his fingers, isn't it? What was that? So I proceeded to do a neurological examination. I found that he had some weakness of extension of his fingers. But extension of his wrist was absolutely fine, no problem. Extension and flexion of the elbow also absolutely fine, no problem. Then I did a sensation test for the sensory deficit, and there were no sensory deficits as well. Only weakness of the dorsiflexion of fingers. That was our finding. Now, I'll share a small clinical video of the same patient. You can watch this video while watching this video, I would like you to tell me what nerve has been injured here. You understand what I am saying here? I am specifically asking him to dorsiflex the fingers. He is unable to do that. I'll show the video once again. The patient has no problem dorsiflexing the wrist, but he has a problem, difficulty dorsiflexing the fingers, and there are no sensory deficits. Okay. So to summarize, this person has the history of trauma. There are no fractures or dislocations. Only problem is dorsiflexion of fingers is weak. That is only his problem. No other problems and no sensory deficits as well. Can anyone tell me what the diagnosis is? Hi everyone. Can you tell me the diagnosis here? Absolutely. Thank you, Dr. Abarna. You're absolutely right. The patient has a finger drop, isn't it? Finger drop. His extension of fingers is lost. This is what you call as finger drop. This occurs because of paralysis of your posterior interosseous nerve. Very, very good. Very good answer. Posterior interosseous nerve injury, which is a pure motor nerve. That is why there are no sensory deficits. Understood. So posterior interosseous nerve passes very close to the proximal part of the radius, near the radial head and neck. So what happens is that when there is an injury there, usually either a fracture of the radial neck or a dislocation of the radial head, you can get a posterior interosseous nerve injury. But rarely, even without any fractures, like the case that we just saw, just because of an external trauma, there could be a posterior interosseous nerve injury, and the patient will present to you with finger drop. All right. So this is the case. Now there is a small topic that I would like you to learn, which is localization of radial nerve injuries. Now this is a very important topic and very regularly asked for your exam. So this is a case where there is finger drop, no sensory deficit. Sometimes they will ask you, a patient will come with or a patient has come with finger drop with sensory deficit. What is the level of the injury or which bone is fractured? Or sometimes they will tell you that there is wrist drop and sensory deficit, which is the area of injury. So in order to identify these, you need to know how to localize the injuries on a radial nerve. And for that, obviously, you will need to know the course of the radial nerve. Course of the radial nerve. So this is a very simple thing. I think most of you would have already learned this. The course of the radial nerve, isn't it? Where does the radial nerve start? It starts at the posterior cord like this. Starts at the posterior cord, descends down like this, and it binds around this part of the humerus. What do you call this area? This is your spiral groove. Yes. Then it binds around the spiral groove, descends down, and just before the elbow, it divides into two branches. One is the deep branch and other is your superficial branch. Now, deep branch is also known as posterior interosseous nerve. That is what we just learned now. Deep branch is also called the posterior interosseous nerve, and the superficial branch is your superficial radial nerve. The most important thing is that here at the elbow, radial nerve splits into its motor branches and the sensory fibers. All the sensory fibers will form the superficial radial nerve, and all the motor fibers will form the posterior interosseous nerve. So this means that posterior interosseous nerve is a purely motor nerve and superficial radial nerve is a purely sensory nerve. Okay. Now, if you look at the branches of radial nerve, this is also very important. There are several branches starting from the axilla till the forearm. If you look at the first branch of radial nerve, it is given off in the axilla. This is a very important branch. This branch supplies the long head of triceps. And what is the function of long head of triceps? Extension of the elbow. Long head of triceps causes the extension of elbow, and this is the most proximal elbow extensor. Why is this important? Now, just imagine a condition where there is a radial nerve injury to a patient and he has lost his elbow extension power. What does that mean? Where is the level of injury? It is very high up, isn't it? The injury has to be proximally high up in the axilla. Then only the patient will lose his ability to extend the finger. And this is a very, very rare scenario to get a injury high up in the axilla. So these kinds of injuries are very rare. That is why commonly radial nerve injury is not associated with elbow extension loss. Now coming distally, the radial nerve will also supply the triceps medial and lateral head, the anconeus, brachialis, supinator, brachioradialis, and immediately after it pierces the lateral intermuscular septum, it supplies the extensor carpi radialis longus. Now, this is also a very important muscle. Why? What is the function of extensor carpi radialis longus? Wrist dorsiflexion. This is the most proximal wrist dorsiflexing muscle. Now, why is this important? So, in order to produce a wrist drop, you need to have an injury to this branch, isn't it? So, the level of injury should be at or above the level of the lateral intermuscular septum. Only if there is an injury at or above the level of the lateral intermuscular septum, especially in the spiral groove here, then only there will be a wrist drop. So a loss of extensor carpi radialis longus will result in your classical wrist drop. Now coming down, you have the posterior interosseous nerve and the superficial radial nerve in the forearm. And posterior interosseous nerve supplies lots of muscle, especially the extensor digitorum, extensor digiti minimi, extensor carpi ulnaris, abductor pollicis longus, extensor pollicis longus, extensor pollicis brevis, and extensor indicis. And all these are your finger extensors. These are your finger extensors. And what happens when the posterior interosseous nerve is damaged? Finger extension will be lost. That is why you get your classical finger drop. That is what we saw here, isn't it? You get the finger drop. No, these are your motor supply. Now, which are the sense areas supplied by the sensory supply of the radial nerve? If you look at the radial nerve, it supplies majority of the posterior aspect of the arm and the forearm, and also the lateral 3.5 fingers in the dorsum, isn't it? We all know this. But it is very difficult to elicit sensation in all these extensive areas, isn't it? So in order to analyze the radial nerve injury, you don't have to elicit sensations in all these areas. You just need to elicit on one area, which is the autonomous zone. Now, what is this autonomous zone? Autonomous zone is a area of the skin which is supplied exclusively by a single nerve. A part of the skin which is supplied exclusively by a single nerve. In the case of radial nerve, it is the dorsum of the first web space of hand here. Dorsum of the first web space of hand. So if you need to test the sensations in radial nerve, you just need to touch here and ask the patient, can you feel anything, or is there any paresthesia or altered sensations? That is all that you need to do. Understood? Okay. So with this basics in mind, we go to the final step, that is understanding the site of the radial nerve injury, and based on the site of the radial nerve injury, the clinical features will be different. So based on the site, there are 4 types of radial nerve injury. Either you could get a very high radial nerve injury, or there could be a high radial nerve injury, or a low radial nerve injury, or a posterior interosseous nerve injury alone, or a superficial radial nerve injury. So in order to learn this, you need to know this very simplified diagram of the course and branches of the radial nerve. So this is what we already learned, but I have simplified it to understand the various locations of injury. So this is nothing but the radial nerve coming down through the axilla, giving of the first branch, which is the branch to the long head of the triceps. then it descends down through the spiral groove, pierces the lateral intermuscular septum, gives off a branch to the extensor carpi radialis longus, which is the first wrist dorsiflexor or first wrist extensor. Then the radial nerve descends down, splits into the posterior interosseous nerve, which is purely motor, and the superficial radial nerve, which is purely sensory. Now, what is this very high radial nerve injury? In very high radial nerve injury, what happens is that there is a injury very high here. Okay, very high up in the axilla. So what happens when there is an injury very high up in the axilla? What will happen to the long head of triceps? It will not work, isn't it? It will stop functioning. So the patient will have a loss of elbow extension. This is very rare, but this you need to know for your theory basics. Okay. Then what happens to the ECRL, extensor carpi radialis longus? It will also stop functioning. So the patient will have wrist drop. The pin will also go, so finger drop will be there, and the superficial radial nerve will also stop functioning, so there will be loss of sensation. So in very high radial nerve injury, there will be loss of elbow extension, wrist drop, finger drop, and loss of sensations. This is very, very rare and usually associated with brachial plexus injury. Now, if this is very rare, what is more common? In fact, the most common type of radial nerve injury is your high radial nerve injury. What is high radial nerve injury? Here, there is an injury to the radial nerve, usually in this area, in the spiral groove. Okay. Anyway, the injury should be above the level of the lateral intermuscular septum. So what has happened to the long head of triceps? It is spared. Long head of triceps is spared. So will the elbow extension be gone? No. Elbow extension will be intact. So there won't be any problem with elbow extension. Only problem is with extensor carpi radialis longus, where the patient will develop wrist drop. And obviously the posterior interosseous nerve and the superficial radial nerve will be lost. So this patient will present to you with finger drop as well as sensory loss. So in high radial nerve palsy, you will have wrist drop, finger drop, and sensory loss. Understood? Okay. Now, which are the examples of high radial nerve injury? I think you all know this, isn't it? You all know the common causes of high radial nerve palsy, isn't it? You have your crutch palsy, then you have your Saturday night palsy and Holstein-Lewis fracture, isn't it? What is this crutch palsy? Crutch palsy occurs when a patient using crutches uses a very long or a tall crutch. So when he is weight bearing on the crutch, there will be pressure on the proximal part of the arm, and especially on the radial nerve, causing neuropraxia. Neuropraxia is just a temporary conduction block of the nerve, and this will cause a paralysis of the wrist extensors. So you get your wrist drop as well as finger drop and sensory loss. Then you have Saturday night palsy. In Saturday night palsy, what happens is that you know what happens on Saturday night, isn't it? So people will go out for enjoyment and they will consume alcohol, get inebriated, and sleep on the bar stool like this, with the arm dangling behind like this, and the arm will be resting on the back support of the chair. And this will cause compression of the radial nerve, again cause a high radial nerve palsy. Finally, we have Holstein-Lewis fracture. Holstein-Lewis fracture. What is this? Here, there is a fracture here in the distal third part of the humerus. And whenever there is a fracture in the distal third of the humerus, there is a high chance that the radial nerve can get entrapped between the fracture fragments. The radial nerve, which is passing close by, will get compressed between the two fragments of the humerus fracture. And this will result in, again, a high radial nerve palsy. So what is Holstein-Lewis fracture? Fracture of the lower third of humerus with radial nerve injury. This was a very recently asked question in FMGE exam, recently concluded FMGE exam. Okay, very, very important. Okay, the whole radial nerve topic is very important, very often asked for your exam. Then comes your low radial nerve palsy. Here, injury to radial nerve occurs around the elbow, somewhere here. So the long head of triceps and the ECRL is spared. So elbow extension is normal, wrist dorsiflexion is normal, no wrist problem. But the posterior interosseous nerve is damaged. So finger drop will be present. Similarly, the superficial radial nerve is also gone. So sensory deficit will be there. So this is a very interesting condition where there will be finger drop as well as sensory loss. Okay. So if there is a question in your exam and they ask you about finger drop and sensory loss, you do not get confused thinking that, oh, in posterior interosseous nerve, it is a pure motor nerve. There is no sensory loss like that. This means that if this combination occurs, this means that the injury is around the elbow, usually around the lateral condyle of humerus fractures. Okay. This is an example where you get a low radial nerve injury. This is also relatively rare when compared to a high radial nerve injury. Understood? Then we have a posterior interosseous nerve palsy. This is the case that we just saw now. Here what happens? Injury is just here. Only the posterior interosseous nerve is damaged. So the long head of triceps and ECRL is normal. So no wrist drop, no problem with elbow extension. Will there be any sensory deficit? There won't be any sensory deficit because pin is a purely motor nerve. So this is your classical finger drop with no neurological deficit. And which are the conditions that usually produce this pin palsy? Pin actually passes very close to the radial head and neck. Okay, like this. So what happens is that if there is a fracture or a dislocation of the radial head like this, fracture of the radial neck or a radial head dislocation, you can get a compression of the pin, posterior interosseous nerve, and a pin palsy. And you can also get this as a complication of Mondagia fractures, isn't it? What is Mondagia fracture? Mondagia fracture, what is it? Mondagia fractures, there is a fracture of the proximal third of the ulna with radial head dislocation. Again, radial head dislocation causing a posterior interosseous nerve injury. Understood? Finally, we have superficial radial nerve injury. Here, there is exclusive injury to the superficial radial nerve. So, will there be any motor loss? No, there won't be any motor loss at all. Elbow extension will be normal. There won't be any wrist drop or any finger drop. Only some paresthesias around the posterior aspect of the forearm and the first web space. Or some of the first web space will be there. And which are the conditions which can produce a superficial radial nerve injury? One is wrist injuries. Wrist injuries, or while you are doing surgeries around the wrist, or in a condition called chiralgia paresthetica. What is chiralgia paresthetica? Can you tell me? Chiralgia paresthetica? Yes, chiralgia paresthetica is a condition where there is a compression neuropathy of the superficial radial nerve. Compression neuropathy of the superficial radial nerve. You must have heard about carpal tunnel syndrome, isn't it? Which is compression neuropathy of the median nerve. Similar to carpal tunnel, when there is a compression neuropathy of the superficial radial nerve, you call it chiralgia paresthetica. This is an MCQ for your exam, right? So this is a summary of what we have learned so far. Okay. Just by knowing the clinical features, you can easily identify the level of radial nerve injury, whether it is very high, low, pin palsy or superficial radial nerve palsy. What are the features of very high palsy? Everything is lost, isn't it? Elbow extension, wrist extension, finger extension, and sensations. Everything is lost. In high palsy, elbow extension is normal, wrist extension, finger extension, and sensations are lost. What about low radial nerve palsy? Elbow extension and wrist extension is normal, finger extension and sensations are lost. In pin palsy, everything is normal except for finger extension. So the patient will develop finger drop. And finally, you have the superficial radial nerve injury where there is no motor deficit. Only problem is loss of sensations. Understood? Okay. Now, how do you treat these conditions, whether there is finger drop or wrist drop? This is very important. The splint that you use is cock up splint, isn't it? This is also a very important spotter for your exam. Has been asked multiple times. Cock up splint. This is your cock up splint, which you can use for supporting the fingers and the wrist and for correcting the deformity. And you can also give methylcobalamin or vitamin B complex along with a short duration of steroids for recovery of the nerve. Okay, so this is how you treat a radial nerve injury. Is there any doubts that you have? If there is any doubt, please don't be hesitant. You can ask me here. Yes, Dr. Aparna, Dr. Akshay, all of you are correct. Very good answers here. Do you have any doubts? Okay, then probably it's time to wind up. So thank you for your patient listening. It's already quite late and you have given your precious time for me. I thank you for that. And you can ask any doubt. I have an active Instagram page, Simply Orthopedics, where I have several followers and I regularly interact with them. If you have any doubts, you can ask me any doubts there. No problem at all. Welcome for your doubts. Welcome for your suggestions, anything at all. All right. So good night. Let's wind up for now. All right.